There is a symptom that shows up on average 3 to 5 years before a heart attack. It is not chest pain. It is not shortness of breath. It is not high blood pressure, at least not that you would notice. It is something that most men over 60 have quietly filed away as a normal part of getting older. Something they have not mentioned to their doctor. Something they feel uncomfortable even naming in a medical context. Erectile dysfunction is a cardiovascular warning sign, and the research on this has been consistent and clear for over 2 decades. I want to talk about sexual health today, all of it, not just the cardiovascular connection for men, but the full picture that affects people in their 60s, 70s, and beyond. The changes in testosterone and what they actually mean. The condition affecting the majority of postmenopausal women that almost nobody talks about. The drug interaction in this space that can be genuinely life-threatening. And the data on what sexual health actually does for your longevity. This is a topic that gets very little serious, high-quality attention on platforms like this. And the consequence of that silence is that people dismiss symptoms, avoid conversations with their doctors, and misinformation that matters for their health. I'm Dr. Marcus Whitfield. I'm an AI avatar, and everything in this video is drawn from published medical research. This is for education, not personal medical advice. Please talk to your own doctor about your specific situation before making any changes. Let's get into it. The cardiovascular connection, the warning sign most men miss. The lining of your blood vessels is called the endothelium. It is a single cell layer thick, but it is one of the most metabolically active tissues in the body. It regulates blood flow, controls inflammation, and produces nitric oxide, the molecule responsible for vascular relaxation. When the endothelium starts to dysfunction, blood vessels lose their ability to dilate properly. Blood flow becomes restricted. The penis has some of the smallest diameter blood vessels in the body. Restricted blood flow shows up there first, before the coronary arteries cause symptoms, before a stress test would flag anything, before chest pain begins. A landmark study published in the Journal of the American College of Cardiology in 2005 followed over 9,400 men and found that erectile dysfunction was an independent predictor of cardiovascular events, heart attacks, and strokes, even after controlling for traditional risk factors like smoking, blood pressure, cholesterol, and diabetes. A 2018 meta-analysis in JAMA Internal Medicine, pooling data from over 150,000 men across multiple studies, confirmed that men with ED had a 59% higher risk of cardiovascular events than men without it. The researchers involved have been very clear about the implication. ED is not simply a consequence of cardiovascular disease. In many men, it precedes it. It is the canary in the coal mine. This means something very practical. If you are a man over 60 and you have noticed changes in erectile function that you have attributed to age or stress or fatigue, that is worth bringing to your doctor. Not because the ED itself is the emergency, but because it may be the first visible sign of endothelial dysfunction that deserves cardiovascular evaluation. A conversation that could lead to earlier intervention on something that actually matters for how long you live. The mechanism connects directly to the broader longevity picture I talk about on this channel. Endothelial health is central to cardiovascular aging. The things that protect endothelial function, regular physical activity, controlled blood pressure and blood sugar, not smoking, good sleep, are the same things that improve erectile function. This is not a coincidence. They are the same biological system. Testosterone after 60, what the decline actually means. Testosterone levels in men decline gradually beginning around age 30, at roughly 1 to 2% per year. By 60, many men have testosterone levels that are meaningfully lower than they were in their 40s. This is a normal physiological process. It is also a process with real consequences that are frequently under-recognized. The symptoms of low testosterone in men are often attributed entirely to aging, fatigue, reduced muscle mass, increased body fat, particularly around the abdomen, reduced motivation, mild cognitive changes, sleep disruption, reduced libido, and changes in mood. These symptoms are real, and while aging itself contributes to them, testosterone decline is a significant driver that is at least partially addressable. The connection between testosterone and sarcopenia is one of the most clinically important and least discussed areas in geriatric medicine. Sarcopenia, the progressive loss of muscle mass and strength, is one of the strongest predictors of mortality, fall risk, and loss of independence in older adults. Testosterone is a primary anabolic signal for muscle tissue maintenance. As testosterone falls, the ability to maintain muscle mass declines. Regular resistance training becomes both more important and, in some men, less effective without adequate hormonal support. A 2019 systematic review published in the Journal of Clinical Endocrinology and Metabolism analyzed the relationship between testosterone, muscle mass, and physical function in men over 60. The findings confirm that testosterone deficiency is independently associated with reduced muscle mass and impaired physical performance, and that this relationship persists even after controlling for age, body weight, and activity level. I want to be clear about something. I am not making the case that every man over 60 should be on testosterone therapy. That is a clinical decision with individual risk-benefit considerations that belongs in a conversation with your physician. What I am saying is that the symptoms are real, the mechanism is documented, the connection to muscle loss and physical function is established, and if you are experiencing these symptoms and have not had a conversation with your doctor that included testosterone measurement, that conversation is worth having. Sleep is one of the most underappreciated drivers of testosterone decline. The majority of daily testosterone production occurs during sleep, particularly during deep, slow-wave sleep. Chronic sleep deprivation or untreated sleep apnea, which I will note is extremely common in men over 60, can significantly suppress testosterone production independently of age. Before any other intervention, optimizing sleep quality is the most accessible lever for supporting hormonal health in this population. The drug interaction that can be fatal, what your doctor needs to know. I need to spend time on something that belongs in every serious discussion of sexual health in older adults, and it is a safety issue, not just a lifestyle one. Medications known as PDE5 inhibitors are commonly prescribed for erectile dysfunction. They work by increasing nitric oxide signaling in blood vessels, which supports vascular relaxation and blood flow. They are effective and generally well tolerated in appropriate patients. However, there is one drug interaction involving this medication class that can produce a severe, potentially fatal drop in blood pressure. Nitrates. Nitroglycerin used for chest pain. Long-acting nitrates used for angina. Isosorbide mononitrate. Isosorbide dinitrate. These are among the most commonly prescribed cardiac medications in men over 60. The combination of a PDE5 inhibitor with any nitrate medication can cause profound, life-threatening hypotension. This is not a theoretical concern. It is a documented, well-established interaction that the FDA has required strong contraindication labeling around for over 2 decades. The reason I am raising this here in detail is that the scenario most likely to produce harm is someone who obtains a PDE5 inhibitor through informal channels, or who began a PDE5 inhibitor before being placed on a nitrate for cardiac reasons, without disclosing the combination to their physician. The fact that these medications exist in different clinical compartments in many patients' minds, one for heart, one for sexual function, means the combination sometimes does not surface in a standard medication review. If you take any nitrate medication, you cannot take a PDE5 inhibitor. That is not a preference or a caution, it is a hard contraindication. If you are uncertain whether any of your medications are nitrates, your pharmacist can tell you in under 2 minutes. Beyond nitrates, PDE5 inhibitors can also interact with certain blood pressure medications, particularly alpha blockers, to produce significant blood pressure drops. Any discussion of these medications belongs with your physician, who can review your full medication list and cardiovascular status. Sexual health in women after 60, the condition affecting most postmenopausal women. I want to address the other side of this conversation directly because sexual health after menopause affects the majority of women in this age group and receives far less attention than the men's side of this discussion. Genitourinary syndrome of menopause, which used to be called vaginal atrophy, is estimated to affect between 50 and 70% of postmenopausal women. It is characterized by thinning, dryness, and reduced flexibility of vaginal tissues as estrogen levels decline. Symptoms include pain or discomfort during intercourse, vaginal dryness, itching or burning, and in many women, recurrent urinary tract infections. The recurrent UTI connection is particularly important and frequently missed. The vaginal and urethral tissues share estrogen receptors. When estrogen falls after menopause, the protective lactobacillus-dominated vaginal microbiome shifts. The tissue becomes thinner and more susceptible to infection. Many postmenopausal women experience recurrent urinary tract infections for the first time in their lives and spend years on repeat antibiotic courses without addressing the underlying hormonal cause. A 2014 study published in the New England Journal of Medicine established that local vaginal estrogen therapy, a low-dose estrogen applied directly to vaginal tissue, significantly reduces recurrent UTIs in postmenopausal women. The critical distinction here is between local vaginal estrogen, which produces minimal systemic absorption, and systemic hormone replacement therapy, which has a different risk profile and a separate set of clinical considerations. Many women who are not candidates for systemic HRT remain eligible for local vaginal estrogen treatment. This is worth exploring with a gynecologist or urogynecologist if recurrent UTIs or vaginal discomfort have been ongoing issues. Pelvic floor dysfunction is a related and equally under-discussed topic. The pelvic floor muscles weaken with age and with the hormonal changes of menopause. This contributes to urinary incontinence, urgency, and discomfort. Pelvic floor physical therapy is an evidence-based intervention for these symptoms that is significantly underutilized, primarily because neither patients nor their primary care physicians routinely raise it. The cultural dynamic here deserves acknowledgement. Women are far less likely than men to raise sexual health concerns with their physicians, and physicians are far less likely to ask. A 2019 survey published in Menopause found that fewer than 25% of women with genitourinary symptoms had discussed them with a healthcare provider. Symptoms that are treatable, that have documented effective interventions, go unaddressed for years because of a combination of patient hesitation and clinical inertia. If you are a postmenopausal woman experiencing vaginal dryness, discomfort during intercourse, recurrent urinary tract infections, or pelvic floor symptoms, these are medical issues with medical solutions. They are not simply the price of aging. Bringing them to your gynecologist or primary care physician is not overreacting. The data on sexual activity and longevity. I want to end this section of the conversation with something that tends to surprise people, because the research on it is more robust than most people realize. Regular sexual activity in older adults is associated with measurable health benefits. This is not a lifestyle preference argument. The data is interesting. A prospective cohort study published in the BMJ in 1997, following nearly 1,000 men over 10 years, found that men with higher frequency of orgasm had significantly lower all-cause mortality. A 2010 study published in the American Journal of Cardiology found that men who reported sexual activity twice weekly or more had lower rates of cardiovascular disease than those who reported less frequent activity, even after controlling for physical fitness and other confounders. Researchers attribute part of this to the cardiovascular exercise component, part to the hormonal effects, and part to the stress reduction and relationship quality factors that are themselves associated with longevity. For women, a 2017 study published in JAMA Internal Medicine, drawing from the Women's Health Initiative, found that women who reported satisfying sexual activity had lower rates of cardiovascular disease compared to women who reported no sexual activity after controlling for multiple confounders. The mechanism is not fully understood. Nitric oxide release, cardiovascular conditioning, hormonal effects including oxytocin, and the mental health and relationship quality dimensions all likely play roles. What is clear is that the framing of sexual health as separate from general longevity medicine is not supported by the evidence. It belongs in the conversation. The practical picture. Here is what I want you to take from today. If you are a man over 60 and erectile dysfunction has been present for 6 months or more, bring it to your physician. Not as a quality of life issue only, though it is that too, as a potential cardiovascular signal that deserves evaluation. Ask specifically about endothelial function, cardiovascular risk factors, and whether any further workup is appropriate. If you are on any nitrate medication for cardiac reasons, that information must be disclosed to any provider prescribing or recommending medications for erectile dysfunction. No exceptions. If you are a postmenopausal woman experiencing vaginal dryness, discomfort, or recurrent urinary tract infections, ask your gynecologist specifically about genitourinary syndrome of menopause and whether local vaginal estrogen is appropriate for you. Ask about pelvic floor physical therapy. If you have not had a testosterone level checked recently and you are experiencing fatigue, muscle loss, or reduced motivation that seems out of proportion to your sleep and lifestyle, ask your doctor to include it in your next blood panel. It is a simple test. The result will either provide useful information or rule out a variable. And if sexual health has simply not come up in your medical appointments, you may need to raise it yourself. Most physicians will not ask. Most patients will not volunteer it. The result is a category of health that gets systematically less attention than it deserves, for a population where it genuinely matters. Your body's signals at 65 are telling you something. It is worth listening. Everything in this video is for educational purposes only. It is not medical advice, and it is not a substitute for a real conversation with your own physician. Your situation is specific to you. Please talk to your doctor before making any changes.